Welcome to a video on the basics of skin grafts. My name is Dr. Janine Roller and I'm one of the senior plastic surgery residents at the University of British Columbia. The learning objectives of this video include reviewing the skin anatomy, to discuss the basics of skin grafts including skin graft characteristics, their survival, phases of healing, as well as the types of skin grafts. Also, we will review how to harvest and place a skin graft. Skin is the largest organ in the body and covers the body's entire external surface. The thickness of each layer of the skin varies depending on the body region and is categorized based on the thickness of the epidermal and dermal layers. The epidermis is composed of keratinized stratified squamous epithelium and is most superficial. The dermis, which is just immediately below the epidermis, is distinct in that it contains blood and lymph vessels, nerves, and skin appendages such as hair follicles and sweat glands. The papillary dermal layer is made up of loose areolar connective tissue, which means the collagen and elastin fibers of this layer form a loose mesh. Underlying the papillary layer is a much thicker reticular layer, which is composed of dense, irregular connective tissue. This layer is well vascularized and has a rich sensory and sympathetic nerve supply. Finally, below the dermis is the subcutaneous tissue. Below there is a link where each layer is discussed in more detail. A skin graft is a segment of epidermis and dermis that is completely detached from its blood supply and the body, and then is transferred to a recipient site. Skin grafts are used to provide coverage over an area of significant skin loss as a result of a burn, a trauma, or a wound that is not amenable to primary closure, secondary healing, or alternative coverage is not ideal. Skin grafts can be classified according to their source. Autografts is where the donor and recipient sites are on the same individual. Allografts are where the donor and recipient site are from different individuals but of the same species, whereas xenografts is where the donor and the recipient sites are from different species. For the remainder of this video, our discussion will be limited to autografts. In order to have a skin graft survive, the recipient site must be well vascularized and clear of debris and infection. Additionally, the skin graft must be in direct contact with the recipient bed. This allows for the phases of healing to occur. Furthermore, the skin graft should be immobile and free of movement and shearing forces. If there is an accumulation of fluid, such as a seroma or hematoma, between the skin graft and the recipient bed, the skin graft will not take. There are three main phases in which a skin graft takes to the recipient site. First is plasmatic imbibition, where for the first 48 hours, the skin graft survives on the diffusion of nutrients. Second is inoscultation, where the blood vessels in the graft align and connect with the sprouting blood vessels in the recipient site. Finally, neovascularization of the skin graft occurs on day 4 or 5, where the graft is revascularized by ingrowth of new blood vessels, extracellular matrix deposit, and maturation. This results in the stable anchoring of the split-thickness skin graft to the recipient site. Skin grafts can also be classified according to their thickness and can be split thickness or full thickness. Split thickness skin grafts are composed of epidermis and part of the dermis. The donor site heals by reepithelialization from the dermal appendages. A full thickness skin graft is comprised of the epidermis and all of the dermis. Since all of the dermal layer and dermal appendages have been taken with the full thickness skin graft, healing of this donor site must occur by primary closure. Primary contracture occurs when the skin graft is harvested and is seen more in full thickness skin grafts. Secondary contracture, which occurs after it is on the wound bed over a period of time, which is the result of myofibroblasts, is more significant in split thickness skin grafts. Split thickness skin grafts are commonly used to cover greater surface areas, where a full thickness skin graft is used for cosmetically sensitive areas such as in the face, or over areas with great soft tissue needs such as fingertips or over joints. How to harvest a skin graft. In order to harvest a skin graft, there is a certain equipment that are required. This includes tumescence, the electric dermatome, and appropriate blades, mineral oil so that the electric dermatome can slide across the donor site, as well as the skin graft mesher and carriers. Please watch the video attached here. It will go through how to take a skin graft as well as how to place it onto the recipient site. Some differences that can be noted in the video compared to how it is done at Vancouver General Hospital is that here our average split thickness skin graft thickness is 12 1/1000ths of an inch, which is 0.3 millimeters thick. Also, after the split thickness skin graft has been harvested, we typically place an epinephrine and saline soap sponge on the donor site to allow for local vasoconstriction and hemostasis. Following the placement and harvesting of the skin graft, over the split thickness skin graft, which is placed on the recipient site, typically Gelinette, which is a Vaseline impregnated gauze, is placed down, followed by one of the following dressings. Firstly, a vac dressing can be placed, as seen in the video, or a more typical burn dressing can be placed, which includes burn gauze, cling wrap, and tensor bandages. Over the donor site, this dressing is highly variable depending on the surgeon and location of the donor site. This can include Xeroform, Aquacel and a Tegaderm, or a Tegaderm alone. So this concludes our video, and we have covered the following learning objectives of reviewing skin anatomy, discussing the basics of a skin graft, as well as how to harvest a skin graft. Thank you very much for listening.